The honourable member for Bradfield.
Thank you, Mr Deputy Speaker. Mr Deputy Speaker, I'm pleased to rise to speak on the Personally Controlled Electronic Health Record Bill. In principle, Mr Deputy Speaker, having a system of electronic health records is, of course, a very good idea. According to the National e-Health Strategy paper issued in 2008, e-health is the means of ensuring that the right health information is provided to the right person at the right place and time in a secure electronic form for the purpose of optimising the quality and efficiency of healthcare delivery. Mr Deputy Speaker, of course this sounds like an extremely attractive vision. The question before the House this evening is not whether in principle this is a good thing. The question before the House this evening is whether the method being used by this government to seek to deliver on this vision, as embodied in the provisions of the bill before the House this evening, are appropriate and make sense, particularly in light of the fact that while this government may be strong on vision, may be strong on aspiration, as we know, implementation is very far from being their strong suit. In that regard, Mr Deputy Speaker, I want to focus on three issues in the brief time available to me to comment on the provisions of this bill. The first question is, how do you get take-up of the electronic health records system? Secondly, is the timing proposed for the implementation of these arrangements realistic? And is there a risk that this government is falling for one of the most obvious and repeated errors in information technology policy, which is going for the big bang, the big system that's going to change everything and solve every problem? And the third issue I want to speak about, Mr Deputy Speaker, is whether the business model underpinning this system is a realistic one or whether it's a wholly unrealistic one, and therefore there is a huge gap between the funding which is required and the funding which has been allocated. Let me turn firstly to the question, Mr Deputy Speaker, of how to achieve take-up of this new system, of this new application. I think it's an uncontentious proposition that unless there is a high rate of take-up of this application, particularly by doctors and other health professionals in choosing to use this application, in choosing to use this system, unless we see that, then this policy will have failed. The money spent to deliver this system will have been wasted. And against that backdrop, Mr Deputy Speaker, I would argue that there are several critical problems with the approach which is being adopted. The first problem, in my view, is the approach of opt-in rather than opt-out. Now, there is a privacy question which has informed the particular approach which has been taken. I do not want to deal with that issue, but I want to deal with another issue which is a corollary, which is a consequence of the approach which has been taken, and that issue is how many people are likely to use this system, how many people are likely to agree to their records being incorporated within the system, because it is absolutely and plainly obvious that unless as many people as possible have their records contained within the system, then the prospects of the system being a success are not high. Unfortunately, because of the decision to make the system opt-in, the power of inertia will work against most people having their records included within the system. The power of inertia will cause people to keep their personal records, their personal health records, out of the system, and that is not good news if you want to maximise take-up of this system and of this application. The second issue, which is a critical problem, Mr Deputy Speaker, is that the approach which has been taken permits patients to view and then to modify their own records. That is a decision with a critical consequence. The consequence is that doctors and health professionals cannot have confidence that the record of the patient which they access electronically is in fact comprehensive, complete and accurate. And if doctors and other health professionals do not have that confidence, if they fear that the record that they are looking at may omit material and relevant information because an individual has chosen to have that information excised, then they are very unlikely to use these records in the way that the architects of this system would hope that they do. Mr. Deputy Speaker, the related point that I think can be made here is that the approach in designing this system makes an absolutely classic error in the field of information technology. And that error is to assume that all you need to do is implement a new system and then behaviour will change. That once you put the new system in the hands of users, users will automatically take it up. That is a deeply flawed assumption, because what you actually need to do is achieve behavioural change on the part of users. Now, who are the key stakeholders who are going to determine whether or not this system is used, whether or not this system is a success? The key stakeholders are doctors and other health professionals. And if they are uncertain, if they are unpersuaded, if they are unconvinced about the merits of this system, then you can spout all the rhetoric you like about the potential of electronic health records, but you will not achieve anything meaningful. And against that backdrop, Mr. Deputy Speaker, it is surely relevant that the peak bodies representing health professionals, and particularly the Australian Medical Association, have raised, amongst other things, serious concerns about medico-legal risk to which doctors may be exposed if they conduct themselves in reliance on electronic records, which are subsequently discovered to have key information missing. Mr. Deputy Speaker, it is a reality that doctors in particular, and to a lesser extent other health professionals, are key in the health system. They are the gateway to significant decisions and significant behaviours. And unless there is buy-in by doctors and other health professionals, this system will not achieve its objectives, and we will have simply wasted a substantial amount of public money. Mr. Deputy Speaker, there are similarities between the error this government is making with this particular IT system and another major IT system it is implementing, the National Broadband Network, which is there is a failure on the part of this government to think about the marketing issues involved. How do we sell people on the use of this system? How do we persuade, in this case, doctors and other health professionals that it is in their interests to use this system? You cannot simply assume that if you make the system available, that you can force people to use it. And in the health system in particular, that assumption is a grave misreading of the organisational behaviour of key groups of people within the health system, particularly doctors and other health professionals. Let me turn, Mr. Deputy Speaker, to the second serious concern I want to identify, which is that what this government is seeking to do is make a big bang change in information technology applicable to the health system, and in a huge rush. The near universal view in the sector is that the timetable for implementing these reforms is absurdly and unbelievably tight. The date which has been specified of 1 July 2012 is widely considered to be ludicrous. Now, we have seen this government make this error in area after area after area, imposing a deadline so that they can announce it in a media release without thinking through the complex implementation issues. And we have every reason to suspect that the same error is going to be made again. I note, for example, that the Medical Software Industry Association, whose members include Cisco, Microsoft and iSoft, made a very critical submission to the Senate inquiry, noting that the government's approach on this issue has not followed normal business practices in the IT industry, and that the documents issued by the National Electronic Health Transition Authority to software developers were manifestly inadequate. So if one issue is the unrealistic time frame, a second issue which compounds that is the naive belief that we can create here a brand new system which will completely transform everything. This is going to be year zero. This new system will solve every problem. That error has been made time after time after time when it comes to the application of information technology in both the public sector and the private sector, and we are well on the way, under the approach embodied in this bill, to making the same error again, Mr Deputy Speaker. Why is it that when the government's consultants, Deloitte's, commissioned by the Australian Health Ministers Advisory Council in 2008 to develop a plan to guide the national approach to e-health, recommended, quotes, an incremental and staged approach, close quotes. They proposed seeking a specific application which was manageable, achievable and would deliver early benefits. And the one they proposed was electronic prescriptions transfer service between healthcares and pharmacies. In their view, a quick win could be delivered at relatively low risk. They argued that the first step was to connect the care providers, next to enable key information flows, and only then go to the third step of building repositories to accumulate the information contained in those information flows. Unfortunately, this government has chosen to reject that very sound advice. Let me quote from what one witness to the Senate committee, Dr Ian Colclough, had to say on this point. He said, quotes, "It makes good sense to move away from large-scale, all-encompassing national e-health projects and focus on projects which are more modest in scope and geography." Close quotes. He went on to say, quotes, "In that regard, it is a mystery why the Deloitte recommendation to establish a national e-prescription exchange service has not been embraced by NETA and the department," close quotes, and I can only agree with him. The third point I'd like to make, Mr Deputy Speaker, in the brief time available to me, is to ask this question. What is the business model under which it is envisaged that the personally controlled electronic health record system will operate? If you ask any large private sector organisation about how they run their IT systems, it could be Qantas, it could be Telstra, it could be National Australia Bank, it could be any one of a host of large private sector corporates, they will say to you that they assume a cost per customer per year, which is often in the range of several $100s, to encompass all of the costs involved in managing, maintaining and, where necessary, upgrading that IT system. There is no way around the fact that the ongoing costs of running a large IT system are enormous. A one-time allocation of $467 million for a system which is designed to meet the electronic health records needs of all Australians is manifestly inadequate. We do not know the answer of where the ongoing spending is going to be sourced from. Where will the money come from to keep this system operating over successive years? The amount of money which is being proposed here has been described, for example, by Sydney University surgery professor Mohammed Kadra as, quotes, "a drop in the ocean." Mr Deputy Speaker, it is well known that the UK spent some £12 billion on their equivalent scheme to introduce e-health records before the program was scrapped as unsuccessful late last year. That should be a warning to all of us. Mr Deputy Speaker, this is, I regret to say, yet another example of the Gillard government espousing a worthy objective, rushing a media release out, setting an unrealistic time frame and showing that it has manifestly failed to deliver a credible and implementable, robust plan to deliver and execute on its aspirations, and for that reason we have very grave concerns about this bill on this side of the House.